Hello, everybody. I want to thank everybody that's joining the webinar. And now, actually, I want to thank botiss Biomaterials too that invited me to give this webinar. Today, we're going to talk about reconstruction of the alveolar process for late dental implant placement. When we place implants, we know we can go and we have a defected alveolar ridge. We have to go either simultaneous or stage approach. Simultaneously, we can place the implant if we have a correct 3D implant position and the primary stability. But if not, then we go for a stage approach. To have a correct 3D implant position, of course, we know ITI has published exhaustively on that subject. I don't want to go into that right now. It's not our subject anyway. But you see this implant here, obviously it's not placed correctly. No bone graft, maybe too buccal, too deep placement of this implant. And this panoramic x-ray that shows probably that you can place implants. A colleague tried to place the implant without having a CBCT. And the post-op CBCT shows that the implants were placed wrongly. Of course, all of them failed. These are the last two that failed. Look at the vector of the implants outside, of course, outside the bone. Look at this implant right here. Look at where it is. Look at this, the vector. Of course, this happened because there was no bone graft. No bone grafting done before placing the implants, and the colleague tried to place the implant wherever it was bone, but there wasn't any bone anyway, so we ended up with disaster. And we have another case. We have this clinical picture only 1 year after implant placement. That means that something was wrong during implant placement. There was no bone, basically. So lack of bone around implants and incorrect implant placement lead to infections, aesthetic failures, and as I call it, iatrogenic periimplantitis. Because this is not periimplantitis, of course, it's iatrogenic periimplantitis. So we're going to talk about then staged approach for augmentation, and we can do either lateral ridge augmentation, vertical ridge augmentation, or both, depending on the defect that we have. And we know that the bone grafting in these cases is essential because first it provides adequate bone volume for the future implant placement. We have better implant position and angulation. We can achieve that better if we have grafted beforehand. We have an improved implant to crown ratio. We have improved aesthetics, and we have long-term stable results, which is very, very important. So the desired properties, as you know, for the perfect bone graft material is to have all these properties: osteogenetic, osteoinductive, osteoconductive, and osteointegrative. But unfortunately, only one bone graft material has all these, and that's the autogenous bone graft. So the choices of the bone graft that we have is either particulate, block, or we can mix it. We use block and particulate. The particulate is either autogenous, it can be autogenous cancellous bone, or it can be autogenous scrapings, surface scrapings of cortical bone, which I like using, allogenic bone, xenogenic bone, or alloplastic materials. Personally, in my practice, I only use autogenous bone and xenogenic bone. I don't see a reason to use alloplastic material, and I'll tell you why. And I don't see a reason of using allogenic bone, since it's very easy to get a much better result with autogenous bone, even autogenous scrapings, which is really easy to get with a scraper instrument. The block, you can use either autogenous or allogenic, or they have some xenogenic bones that they don't have very good results. Allogenic blocks, in my opinion, they don't have stable results either. And you can use mixed block with particulate. But mainly, as I told you, when I use particulate, I use autogenous mixed with genogenic bone. And genogenic bone is, I use the Sera bone, which is 100% bovine material. And why I use it? Because of this long-term volume stability. What I want from my bone graft is to stay there. I don't want to use a bone graft material to put it in and then after 6 months to resorb away. I want to, the volume that I put in, I want it to stay there. And especially the cases that we're going to see today is when we build outside the bony envelope. So when you build outside the bony envelope, you have to use a material that stays there. When you use, of course, when you're doing a sinus lift procedure, you know that whatever material you're going to put in, it's going to work. But when you build outside the bony envelope, then you have to rely on your bone graft to stay there forever. So you don't want to use an alloplastic material. You don't want to use an allogenic material. You're going to use autogenous bone graft with xenogenic particles that give volume stability. And you see your xenogenic bone, your bone that you use, it has to have the same surface characteristics with the human bone, and if possible to stay there forever. If you use allogenic bone, it has the same surface characteristics, but it will resorb away. The same will happen if you use only autogenous bone as scrapings or as cancellous without any protection. So you want to use something that looks like a human bone as your host bone, but at the same time stays there forever. And that's the xenograft. And the xenograft has, when you use the xenograft, you have to look at the macroporosity, the microporosity, and nanostructure, so that it enhances rapid vascularization and osteoconduction for the new osteoblasts to go in and grow there and grow new bone. And the Sera bone, if you use it alone, then you have to wait for about 9 months for ossification to occur. But if you use it in combination, especially with cancellous bone, you can go in after 4 months. And why I want the Sera bone? Because it doesn't resorb. That's what I want. I want a bovine bone that does not resorb. I know it's only osteoconductive. It's nothing else, but I don't want it to be anything else. For osteoinductivity and the osteogenetic properties, I have them from the autogenous bone. So in a case like that, where we have placed 5 implants here, and the canines are going to be extracted, I want, what do I want to do? I want to preserve these canine eminences for afterwards, for the when we have the final prosthesis, to have nice aesthetic results. So how do I do that? I take out the canines, and then we place in some Sera bone granules that I know that they will stay there forever. I want something to stay there forever, not something that will resorb away. But because if it resorbs away, then this eminence here will resorb away too. So here we used also a couple of gingival grafts, free gingival grafts from the palate to close the hole of the socket. And then the final result, we have it here. You see the canine eminence after the prosthesis is placed, it will stay there forever because we have a material that stays there forever. So when we're talking about blocks, autogenous block, we can get them from the mandible, from the calvarium, from the iliac crest, rib, you name it. We can get blocks from all over the place, but we prefer intraoral harvesting. So mainly we go to the mandible. Why? Because it resorbs less from if you compare it to other bones like the iliac crest. Iliac crest is an endocondylar bone. It resorbs faster and easier. Mandible is a membranous bone. It has less resorption, But some people say that it has less resorption because it has a more cortical component, and I kind of agree. The more cortical the component in your cortical cancellous block, the more it resists resorption. So try to get to the mandible. If you can convince the patient to go to the calvarium, if you need a lot of bone, then yes, but it's not, I know that it's not that easy to convince the patient to have response from the calvarium. Although it has very, very low complication rate, the calvarium. So we used to use autogenous bone blocks by themselves. Lately, we use them with a membrane or with xenograft particles around the block and with a membrane for better results. This is a very, very important issue. When we do augmentation of especially big defects of the alveolus, we have to fixate the graft. And the bad thing about the disadvantage of the particular graft is that it's difficult to fixate and to achieve total immobility. Whereas with autogenous block, we have easier fixation with the titanium osteosynthesis screws. And of course, either we use one or the other, we have to avoid the constant pressure caused by a removable prosthesis. And if we have a removable prosthesis, we have constant pressure as moving of the graft. So we have a lot of papers that show that lateral ridge augmentation with autogenous blocks work. Actually, we're not reinventing the wheel here. We have strong evidence behind the bone blocks. In the older days, we used them without barrier membranes, and we saw kind of a lot of resorption. But lately, if we add xenograft granules and membranes around the blocks, we go down a lot on the resorption rate, and we have a very nice and steady and stable result. And if we compare the bone grafts for the lateral ridge augmentation, you see with a particulate graft, you can have a lot of resorption afterwards. And you only have this kind of bone gain. But if we use autogenous block, even without a GBR membrane, you get better results than a particulate bone. And of course, if we use the autogenous block with a GBR membrane, we get the best results, especially if we combine it with the xenograft granules. These are two very nice articles that show only 5 to 7% resorption rate after 5 to 14 months or at implant placement re-entry surgery. If we combine, as we said, autogenous block with xenograft granules and GBR membranes. Very, very nice article. Whoever is interested, Jensen and Terhayden, International Journal of Oral Maxillofacial Implants in 2009. Actually, it's a consensus statement of the fourth ITI consensus statement. They looked at a lot of studies on that subject. And actually, if you see this slide that I presented here, I don't know why you would go for a particular bone graft after that. I mean, horizontal gain, look at that, 4.4 millimeters gain, only 2.6 millimeters of gain with a particular bone. But the big thing is here. Look at the complication rate, only 3.8% with a block graft, and almost 40% with a particular bone. It may be small complications, maybe large, big complications, but who wants complications in their private practice? I work in a private office. I have my private office. I don't want patients to be calling me all of the weekends, weekdays, nights with complications. I want to do the surgery and get it over with, and I want to have a happy patient. A happy patient makes me happy too. So I want less complications. The less complications I have, the better. So I like that. I like less complications. So I'm going to go for the surgery that brings less complications. And I want my patient not to have to pay more again during re-entry surgery for implant placement. So look at that, 2.8% I have to regraft when I put my implants. Almost 25%, 1 out of 4 cases, I'll have to regraft if I use particulate bone to reconstruct the alveolus. So my patient has to pay again. So I make things more complicated. Why do I have to complicate things? I know that the autogenous bone block is a more difficult and demanding procedure. Maybe sometimes it's less acceptable and appealing to the patients, but sometimes the best is not always the easier. So I think we have to go with the best. So the fourth ITI Consensus Conference came up with this statement: utilizing autogenous blocks results in higher gains in ridge width than particulate grafts. So our clinical decision: is it necessary to use only autogenous bone blocks for the stage reconstruction of one wall defect? I say one wall defect because it's the most difficult defect to reconstruct. So is it necessary to use only blocks for these defects? And the answer, of course, is yes, if we want to be successful and long-term successful and with less complications. So if you have this kind of defect, one wall defect, the best way to reconstruct it is with an autogenous bone block fixated with a couple of titanium screws, around it xenograft granules, and above it GBR collagen membrane. Which is the best donor site of autogenous bone blocks for intraoral alveolar crest reconstruction? Well, we're going to try to stay intraoral. So we're going to go either to the lateral oblique ridge of the mandible or to the chin. If we have larger reconstructions and we want a lot of bone, then we may consider going to an anterior iliac crest ridge or to the calvarium. But almost 99% of the cases, we stay intraoral. This is a nice study done to check the revascularization of the blocks taken from the external oblique ridge. So after a mean of 5.2 months, vitality of the only blocks is already 42%. They have ongoing bone remodeling after 9 months, and we can expect it to continue remodeling as time goes on. Now, this is a study of the revascularization of the chin bone blocks, even better now. 4.2 months mean time, vitality of the only blocks 89%, and after 7 months exclusively vital bone. So we can say probably that the chin bone blocks are probably the best way to reconstruct the alveolus. But unfortunately, when the patient is dentate and you take the block from the chin, they tell you that they feel numbness on the teeth. Actually, they have this wooden feeling on the teeth. So when the patient is not edentulous, we try to go first to the external oblique ridge, and if we want a lot of bone, then we can go to the chin. So after all this, then we can say that we don't need any bone substitutes. Of course we need them. And first we need them for sinus floor elevation. You can use whatever graft you like. We can use it for a GBR with simultaneous implant placement. We can use bone substitute when we want volumetric stability, when we do contour augmentation, especially outside the bony envelope. And that's where we want something that doesn't get resorbed. So we want a xenograft that stays there. We mix it, as we said, we mix it with autogenous bone to minimize resorption. Again, minimize resorption means that we're going to use xenograft, nothing else, because nothing else minimizes resorption and looks like human bone. And we use it for alveolar crest preservation and in pontic areas, as we said. Again, xenograft bone. Now let's go fast to talk about barrier membranes. Do we use them? Of course we use them. Back in the 80s and the 90s, we said, oh, we don't really need membranes. We cover the bone graft with the periosteum. That's not the case. we have to cover our graft with a barrier membrane, because the osteoblasts that go into our graft are coming from the surface of the recipient side, not from the periosteum. So we have to protect the graft with our membrane. Protecting means we prevent the faster growing soft tissue cells of invading the slower growing bone regenerate. So we make way for the osteoblasts to come from the osseous surface into our graft. And the membranes create space under the membrane for the bone regeneration from the recipient side, as I told you. Membranes help contain and stabilize the graft particles within the osseous defect. And this is very important. When we put the xenograft granules around our block, we want them to stay there. If we don't put a fixated membrane, after we close the flap, the particles may travel, go mesial, distal, you name it. So we have to make sure that the particles stay there. And of course, when they stay there and they're contained, they provide the support for the blood clot to stay there too. We all know that the absorbable collagen membranes are more tissue friendly than the non-resorbable ones and lead to less complications, more tissue friendly. But remember, resorption time is not the same as barrier function time. If a manufacturer tells you that the resorption time of the membrane is 2 months or 3 months, remember that your barrier function time will be much less than that. So try to get a membrane that lasts longer, has a longer resorption time. You're going to have a longer barrier function time. And unfortunately, I know that you want to use stuff that are user-friendly, but as far as membranes is concerned, if you prefer more user-friendly membrane, you have to probably settle with shorter barrier function time. Unfortunately, the membranes that last longer are not that user-friendly, but they work better, and I like them to work better. I don't mind being a little bit frustrated when I work, as long as what I put in there gets me to where I want with better results. And I use the adjacent membrane because it's a native collagen membrane, and it has naturally long barrier function. It's thin and it's extremely it has a lot of strength. Tear resistant. I can pin them, I can suture them. You can see, you will see it afterwards when we show some cases. And it's naturally cross-linked. It comes from pericardium, and it's very thin, but it has a smooth surface that goes towards the gums and towards the periosteum, and the rough surface that goes towards the bone graft. So you see, it is naturally cross-linked. It's pericardium, and it's really tear resistant. Even if it's wet, you wet it with blood, or you wet it with saline, whatever you want. But it's really tear resistant. I like to pin it and pull it down to cover my my graft, and it stays there, and I can suture it under my palatal flap. It doesn't get torn, and it stays there for about 3 to 6 months. So I want it to stay there longer. The longer, the better. I know it's not that user-friendly as other membranes, and I can tell you, if you want to have the better result, if you want to have the better results, you have to pin these membranes. You have to pin them, put your graft underneath, and then suture them under the palate. Don't try to make them stick like that. It's better if you pin them. So if you ask me what's my treatment sequence in dealing with big cases like that, I try not to do all magic things at once. I try to go one step at a time. So first stage, we just do the extractions, the debridement of any infected tissue, and we manufacture an interim prosthesis for the patient. We wait for about 2-3 months for the soft tissues to heal completely, and then we do our bone augmentation with the autogenous bone block, the xenograft granules, long-term collagen membrane, and then, of course, before the patient goes away, we remodel the interim prosthesis to avoid pressure on the graft. After 6 months, we do our implant placement. Again, we remodel the interim prosthesis to avoid pressure on the implants. 3 months after that, after osseointegration has taken place, we do the implant uncovering if we have submerged them, plus or minus a connective tissue graft. I can tell you now that if you overgraft with bone, you very, very seldom will need to have a connective tissue graft. Lately, I very, very seldom use that because I try to overgraft with bone, autogenous bone and xenograft. And then we have the dentist. I have the dentist because I only do surgery. I have the dentist to remodel the interim prosthesis to achieve the better tissue sculpture for emergence profile. And after 1 to 3 months, we do the final restoration. So when we use autogenous bone grafts, we have to know their biologic behavior, when to use cortical and when to use cancellous. We're going to talk about that. We have to know our donor areas, and we have to come up with an anesthetic plan. Many times we have to go for sedation or even general anesthesia for these big cases. Cortical versus cancellous. The cortical is somewhat osteogenic. It has the cortical bone has few osteoblasts in there. It's slowly revascularized because it's hard. It doesn't have a lot of spaces, but it provides structural support. We can easily fixate it, and it has a very slow bone turnover, and it's more resistant to resorption. On the other hand, cancellous bone is more osteogenic. It's full of live osteoblasts, is rapidly revascularized, which is good, but it doesn't give us structural support, so we have to find a way to fixate it somehow. It has quick bone turnover, so it may resorb faster if it's outside the bony envelope and if it's in areas where, if it's in the pressure bearing area. So we have to combine this bone with xenograft granules to resist resorption. We're not gonna go into that. We said that almost. We mentioned all of this almost, but I want to show you the bone shavings. It's a very, very nice source of autogenous bone, cortical bone, but it's particulate, and it's full of BMPs, and it's an osteoinductive bone graft. So I would better use this instead of why not use this and use instead of an allograft. I mean, the allograft materials that are out there in the in the market right now, many of them say that they are in osteoinductive, but really very few of them are. But it's easy to take bone shavings from your patient. It's going to take you about maybe 10 more minutes from the same area where you work, and no more incisions. You're right there. It's better to take it from there, and you're going to have a better quality bone graft. So when we're talking about the staged alveolar ridge bone grafted for a staged alveolar ridge defect, we're either going to use an only autogenous bone block, as we said, with xenograft and a membrane, or we can use a very thin block. That's Professor Curry's technique, very, very thin block. We fixate it away from the recipient bed, and we pack the in-between area with autogenous cortical bone shavings, and we modify this technique by using also xenograft and the GBR membrane. But because this, I used to use this technique a lot, but lately I kind of stopped using it because I see that the first technique with the only autogenous bone block and the xenograft and the membrane works perfectly. So why do I have to go for a more tedious procedure? Sometimes you can use it if you want very, very large augmentation. So you fixate this thin block way from your recipient bed, and so you create like a space of 5 or 6 or even 7 millimeters width, and you put in there only autogenous and xenograft and GBR membrane up top. But usually, like 90% of the cases, you can get away just with autogenous bone block. Sometimes, and we're gonna show you a couple of cases, we can go for autogenous cancellous bone plus xenograft plus titanium mesh or a GBR membrane. This we have to go to this technique when we have larger reconstructions to do. Even larger reconstructions, we have mandibulectomies or maxillectomies, we go for a free vascularized bone flap. We're not going to go into that today. And sometimes we need to augment the soft tissue by using connective tissue grafts or palatal connective tissue periostal rotational flaps. So today's webinar is basically about that. How do I go from this to this predictably? Probably I can ask 10 people to tell me the answer to this question, and I will get 10 different answers. But what I want is something predictable, something reproducible, and something that will give me a long-term result that will stay there forever. So if I want that, I will go with an autogenous bone block with a xenograft and the membrane. So the successful ridge augmentation with autogenous bone block, we have to choose correctly for our donor site. We have to have a large contact surface area between the graft and the pre-existing bone at the recipient side to get a lot of osteoblasts from the recipient side into our graft. Very, very important. Again, rigid fixation of the graft. If the graft is not rigidly fixed, you're going to fail. It's as simple as that. Rigid fixation protects the neoangiogenesis from the host to the grafted bone and ensures graft incorporation. Use of xenogenic bone particles around the bone block to reduce resorption. Protection of the graft, again, as we said, with absorbable collagen membrane, preferably long-term membrane and preferably stabilized with pins and sutures. Very, very important, again, tension-free primary flap closure. If you want to do big ridge augmentations, you have to master tension-free primary flap closure, because you may have done everything right up to that point, and then if you don't do a tension-free primary flap closure, everything you're going to end up with a disaster. And of course, avoid tension from the interim denture. Try to get fixed interim prostheses and not removable ones. So how do we fixate our bone block? We make the hole bigger, larger diameter in our graft, a smaller diameter in our recipient bone, and then as the screw goes in, it slides through the graft and engages into the bone, into the recipient bone, and the graft is getting compressed through the head of the osteosynthesis screw. And around that, we place our our xenograft granules, our autogenous cortical shavings, and the GBR membrane, preferably pinned and sutured. And periosteal release to create a sliding flap for tension-free closure, as we said. So now let's go to see some cases. That's an old case, 1999. You see very narrow maxilla. So we're going to do a maxillary augmentation with autogenous blocks from the chin, no xenograft, no membranes at the time. We said we weren't that big on membranes that far back. So we go ahead, see how thin the maxilla is. We take big blocks from the chin. We put 4 blocks up on the maxilla. But look at that. We have a big cancellous component here and a very thin block here. And we just cover everything with our flap. No membranes, no nothing. So what happens? See resorption after 6 months. We have like almost 40 to 50% resorption here. Only in these 2 blocks, not in the ones posteriorly. Well, we placed our implants back in 1999. We saw that here the bone is thin, but back in 1999 we didn't do much about that. Worked. Still working. Patient still with the prosthesis in her mouth. She's happy, but I'm not very happy because I see here some bone resorption around my 2 front implants. You may say not a big deal, but you know, it may be a big deal. I prefer the bone to be up to here. So, you know, we have to try to do everything as perfectly as possible. So our philosophy changed. We added membranes, we added xenografts in our armamentarium. So in another case, lateral maxillary augmentation with autogenous bone blocks, xenograft and collagen membrane. You see here how thin the right side of the maxilla is. Very, very thin. We cannot do anything else. It's a one-wall defect. Your best bet is to go with a bone block. You see how thin it is? We take a bone block from the external brick ridge. We fixate it with titanium screws. You see the collagen membrane is already tacked, pinned up there apically. We put the xenograft granules around, and we bring the membrane under. We tuck it under the palatal flap, and we suture it. Resorbable sutures. And tension-free closure. We always, in these cases, we always use horizontal mattress sutures. Post-operative panoramic X-ray. You see re-entry in 6 months. Very good bone quality. The blocks, the xenograft granules, totally incorporated in the graft. We have nice bone to place our implants. You see here the final result. And some years after the Panorex. Again, same things. We always do the same thing with the same technique. When you have we have a saying that when you have a team that wins, you don't have to change it. Why change it? Big reconstruction needed here, but we're gonna look at this area here. We do a sinus floor elevation. Lateral augmentation in area of tooth 1-4 with bone block from the external brick ridge. Xenograft, the cerebone around it, you'll see, and see how the Jason membrane is already pinned up there apically. And we put our particulate component of the graft in, and then we bring the membrane under the palatal flap and we suture it. You see the suture here, so that everything stays immobile under the membrane. And primary closure, tension free after periosteum release. And we see that 6 months after that, we place our implants in perfect bone. And that's 4 years post-op. We see the bone levels stable, no resorption at all. Another case like that, same thing, block graft. See how thin the maxilla is. Sinus lift at the same time. Block graft here, we chose the acre block from the chin. And you see here the scraper graft. I call it the scraper graft, and this is a scraper instrument they use to take autogenous cortical shavings. And we fixate the bone graft first, and then after we pin the membrane up there, you see the membrane is already fixed. Then we place our particulate part of the graft, mixing of autogenous and xenograft granules, and we suture it under the palatal flap. It's always the same. The donor side, just a fleece collagen. We don't need to put anything else in there. Closure of the chin, panorex post-op, and very good quality bone to place our implants 6 months after the augmentation procedure. And 5 years post-op, see, the lady needs something else done here, of course, but our implants are stable, very, very stable. And I mean, this is the answer to whoever is saying bone block, because many of my colleagues tell me, oh, you're using bone blocks, they get resorbed. You're like a dinosaur. That's not true. Bone blocks, if you know how to use them, if you know how to do your cases, use xenografts, use GBR membranes, they don't get resorbed. They stay there. And you have very, very good results. That's a 5 years panoramic X-ray. Here, a little bit more difficult case, like a 24-year-old female. He has a history of impacted canine removal. I think it was ankylosed. And she had already 4 surgical attempts for augmentation, she told me. 2 with particulate grafts and 2 with soft tissue grafts to augment the area. I don't know what they were doing with the soft tissue grafts, but anyway. So she came to me saying that, I know that you're not going to do anything, but you know, I just wanted to get another opinion. I said, of course I'm going to be able to do something. The only thing that I won't be able to do probably is, and I want to show you that, you have to tell your patients, look at the papilla on the premolar and look at the papilla on the lateral incisor. From all these surgeries, I don't know which one which surgery is responsible, the papilla has gone up. And why it has gone up? Because the bone has gone up. Okay, so we lost bone here from all these surgeries. So we have to tell the patient beforehand, not afterwards, that here probably the papilla won't be as it was before. Because, and bear that in mind, we cannot graft on cementum. We only graft on bone, not on cementum. So the vertical component of this defect will be reconstructed up to here, not up to here. Okay, because we cannot graft, basically doesn't take on cementum. So it's better to tell that to the patient beforehand. If we tell that to the patient beforehand, they appreciate it. If we tell it afterwards, then that means they say that it's just an excuse. So we have to tell it. So we have to know it and tell it beforehand. So we see the defect here, and we use a bone block from the external oblique ridge. Again, autogenous cortical scrapings, xenograft granules, the Jason membrane pinned and sutured under your palatal flap. Here, I don't remember why, because it's an old case. I don't know, I tried to do the double layer technique. You don't really need to do that. I used a short-term membrane here, but you don't really need to do that if you have fixated your first membrane. And tension-free closure, and you see the quality of the bone that you have in 6 months. That you place your implant correctly in the correct prosthetic position, okay? Not wherever the bone is, but wherever your dentist wants it to be. And 4 years post-op, we see everything stable, and this is stable. Because we knew that the papilla would be there. The patient doesn't matter, he doesn't care. She doesn't care at all, but I just got the picture for myself. She doesn't even notice that. Another case, again, young female, history of central incisor trauma and extraction due to external resorption. Look at this healthy tissue. I want that healthy tissue when I do my surgery. I don't want concavities. I don't want ovate pontics. Try to avoid ovate pontics when you do interim Maryland bridges. So how do we reconstruct that, with an interim prosthesis up to the surgery? We do a Maryland bridge with no ovate pontics to avoid pressure on soft tissues. We want healthy soft tissues for the surgery. After we place the implant, on implant uncovering, do whatever you want with pressure on the soft tissue to sculpture it. But before that, don't do it. We want this healthy tissue to work with. You see how thin the anterior maxilla is? Again, the same stuff. I don't have all the pictures. I have blocks. I mean, it's always the same. I'm telling you, a team that wins does not get changed. Cerebone under there, collagen membrane adjacent. See that on re-entry 6 months after that, after the original surgery. You see here the incorporated xenograft granules and the scrapings around the bone block. Correct prosthetically implant position and the tissue sculpture with screw retained interim prosthesis after second stage surgery, okay? Not before augmentation surgery. We can go from that to have a nice emergence profile. And that's 3 years post-op. That's another answer, whoever says that blocks don't work, okay? Let's go to the mandible. Mandibular defects are a little bit more difficult to work with, more difficult access, more difficult to cut the periosteum to close with to have a tension-free primary closure. You have to watch the mental nerve. You have to be a little bit more experienced for mandibular cases. So in this case, we're going to do a lateral mandibular augmentation with autogenous block graft from the external brick ridge. We're right there, so we can take a block from there. Autogenous bone shavings and collagen membrane. That's an older case. I didn't use any xenograft granules here. See, we take the block and we fixate it right there with the 2 screws. The collagen membrane is already secured with pins. See the pins here. See the autogenous cortical shavings. And this goes above it and under your lingual flap. Closure, tension-free with cutting of the periosteum and matter sutures. And you see the panoramic X-ray, the post-op. And you see the amount of bone that you have gained here. That's where the bone used to be, and that's where it is right now. That's where it used to be, where it is right now. And now you can place whatever implant you want in the correct prosthetic position. Again, correct 3D position. Look at the quality of the bone 6 months after the augmentation. It doesn't get better than that. You cannot even tell that it's augmented bone. Correct prosthetic position. And 5 years post-op panorex. 5 years post-op clinical pictures. Stable results. Again, this is a more recent case. Recently, I've been using this kind of incision. It's an easier incision to close, but you need to be a little more experienced surgeons to do it. It's a mucosal incision. It's the kind of incision that we do when we do mandibular sagittal split osteotomies for orthognathic surgery. So we do it only on non-attached mucosa. You have to really be careful here not to traumatize the mental nerve. But after that, it's easy to work with and it's easier to close at the end. Has no tension. Again, we take the block, same stuff, same always. Mixing of our particulate, autogenous plus xenograft granules. The collagen membrane, the Jason membrane is already secured, brought up, covers the augmented area. And here, in this area, I used, because it was a big reconstruction, and I was afraid of having some dead space under here, I used a couple of gel foam sheets to make this dead space a little bit smaller, to minimize it actually. And actually this stabilizes the clot also. Works good with clot stabilization. And tension-free closure. It's easy to do a tension-free closure with this kind of incision. And again, here you can place your implant wherever you want it, wherever you have to do it. Correct implant placement. Look at the quality of the bone. Look at the quality of the bone. This bone is going to stay there forever. And you don't have to submerge these implants, do healing abutments, and 3 years post-operative X-ray, stable results. And we can do this technique with bigger cases too. This is a case with a total mandibular alveolar augmentation. You see how thin the mandible, the whole mandible is. So we use the autogenous block grafts from the chin and the external oblique ridges. Again, autogenous bone shavings, Serra bone, Jason, it's always the same. See how thin the mandible is. And again, the incision is out here. It's like an apron mucosal incision, non-keratinized on non-keratinized tissue. Block grafts all around. Cover them with Jason membranes after we have placed our xenograft particles and the shavings. And here we see the 6 months post-operative CBCT. We see here how much bone we have gained. All this. And we are able, you remember how the mandible was? Look at that, we're able to place 7 implants after 6 months. And again, the same kind of procedure for the maxilla, very, very thin maxilla, total maxillary reconstruction with autogenous block grafts from the chin and the external oblique ridges. Look at how thin the maxilla is. It's a disaster case. Look at how thin the maxilla is. Actually, in this case, I didn't elevate the flap on the palatal side because if I elevated both flaps, buccal and palatal, I was afraid that this would just resorb away with necrose. So the palatal flap stayed on the bone. You're going to see it now here. Here you see the palatal flap stayed on the bone. I didn't raise that. So blocks all around, and our xenograft granules, autogenous scrapings, pinned, stabilized membranes, tension-free closure, and 6 months after that, look at the bone that we have to place an implant in tooth number 1-6, tooth number 1-4, tooth number 1-3, 1-2. We can place implants wherever we want. 2-2, 2-3, 2-4, 2-6. And we placed 6 implants. and that's at implant uncovering. We do a partial thickness apically repositioned flap to uncover our implants. And this is a 3-year post-operative panoramic X-ray. It shows you the stability of the bone. And actually, I left this screw in there because I couldn't find it. It was so buried in the bone. When I was placing the implants, I couldn't find it. So I said, forget it. Doesn't matter. I'll leave it in there, because to remove it, I would really have to dig into the reconstructed bone. And I'm gonna go fast in that case because I just put it in. It's an old case, but I was lucky enough to have a post-op. It's the same kind of case, reconstruction of maxilla with a chin and xenograft and membrane. But look at the 9-year post-operative CBCT. Look at the 9-year post-operative CBCT. I mean, who says that blocks don't work and get resolved? Look at the block. Look at the block. Still there. Look at the blocks. Look at the perfect position of the implants. I mean, no resorption. So autogenous blocks, if worked correctly, they do work. Let's go just to mention another nice technique that I've been using lately. It's a 3D reconstruction with autogenous bone ring with simultaneous placement of the implant and using xenograft around the whole area to prevent resorption. It's a bone ring technique as described by Dr. Giesenhagen. So we use a corticocancellous ring block autograft. I prefer the autograft and not the allograft, as I told you. I'm all for autografts fixated in the recipient side with the implant itself. And we use autogenous cortical shavings and xenograft Cerabon around the whole, bone ring and implant, and we cover everything with a fixated Jason membrane. And this technique is indicated in cases where we have a loss of both buccal and palatal plates. In a case like that, you see how we have a 3D defect here, and we have to reconstruct that. The height, see the defect here. We take the bone ring. We have already made our bed for the implant placement. That's the bone ring, corticocancellous ring. You see the defect here, but you see that the bone is nice on the root number 1.5. If we didn't have bone here and the bone was up to here and the root was exposed, then we wouldn't be able to graft this area. We would have to remove tooth 1.5 and build on the bone, on the intact bone of tooth number 1.4. But here we were lucky. Tooth 1.5 had bone on the distal. We do a sinus lift simultaneously, and we see we have a nice wide bed for the bone rings to sit, and we place our implants through the bone ring and into the elevated sinus. We have placed two implants, two bone rings for tooth number 1.6 and 1.7. Cerabon around it, Jason stabilized with pins, tension-free primary closure. That's a post-op panoramic X-ray. You see implant uncovering after 6 months. You see a nice bone, the autogenous bone, the xenograft bone incorporated in there. And we have a stable result. Look at how nice the free gingiva look, and how we have a nice post-op panoramic X-ray. Then we have to go a little bit faster to vertical ridge augmentation. Basically the same with blocks and xenograft granules, but it's a little bit less. We have a little bit of a higher resorption rate than a horizontal augmentation, and probably that's due to a smaller contact surface area between the recipient bone and the graft. And again, as we said before, normal mesial and distal bony crests are needed. Do not build on root cementum. So these cases are done the same. We have to build this and this area vertically. That's an older case. We built it just with autogenous block from the external oblique ridge, and we did a sinus lift with cancellous bone from the tibia. We just used the autogenous bone and around the bone from the tibia around this bone block, and stabilized collagen membranes. That's the final result, stable result 4 years post-op. And another vertical augmentation, 30-year-old female after car accident, missing part of the anterior maxilla, a lot of teeth missing, part of the maxilla missing, and we reconstruct that with big blocks from the chin, again membranes, and we see here the reconstructed bone 6 months after augmentation. You see here where we have reached now our bone to be, placing our implants in good bone, and post-op panorex and clinical picture. And we're going to finish up with the cancellous bone autografts. When do we use it? We use it when we have large reconstructions to do and less than perfect recipient sites. Because why? Because we have to rely then on the osteoblasts of the grafted bone. And the osteoblasts of the grafted bone are, we have live osteoblasts and a lot of osteoblasts only on cancellous autografts. So we have to go in extraoral donor sites, either in the iliac crest or on the tibia, which is rich, both are rich in osteoblasts, and with that we succeed with one-to-one osteogenesis with direct new bone formation from the grafted osteoblasts. As soon as we graft them, they start working and producing new bone. So, but we mix it with xenogenic bone to minimize resorption, and we fixate it somehow, either through membranes or through titanium mesh. I don't really like titanium mesh. Has been found to have almost 50% exposure rate in the mouth, so I don't really like using that. I only, when I have intraoral access, I only use membranes to fixate the graft. And you're going to see a couple of cases. Here we see a 22-year-old male, again missing part of the anterior maxilla after a motor vehicle accident. See how much of the maxilla is missing. All this is missing. And now again, we do a straight incision at the depth of the labial sulcus, only on non-attached mucosa at the Lefort-1 level to have easier closure afterwards. And we go to the tibia. We take a tibia bone graft, just a 2.5 centimeter long incision. We take a lot of bone, very, very low morbidity. Patient has a little bit of pain for about 10 days and that's it. Very, very lower morbidity than the iliac crest, of course. And here we have placed our 30 by 40 membrane first, sutured under our palatal flap. We pack our particulate graft, which is the autogenous cancellous graft, along with the xenografts, and then we turn the membrane around and we pin it on the buccal side of the maxilla. So this immobilizes the whole graft. We close primarily tension-free, and that's 1 week post-operatively, and that's the 5 months post-op. You see how much reconstruction we have gained on the maxilla and on the mandible. See how much reconstruction of the maxilla and of the mandible. And we placed, see, nice bone. We placed 3 implants on the maxilla and 2 on the mandible. Here we had a little bit of, I didn't put, I don't remember why I didn't put much bone graft here, so I didn't really need it, but I did place some implant placement. Some cerebone and adjacent membrane above, just for contour augmentation, and non-submerged healing, and the patient with interim prosthesis for tissue sculpture. And I'm going to finish with this case, the 20-year-old patient with alveolar cleft and oronasal communication. These are demanding cases. There is no bone in here to stabilize your graft. So you cannot rely on the host bone to get osteoblasts. From where? From the roots. We only have a very thin bone covering the roots here. So we have to rely on our grafted bone to start producing bone right away. So we need to have cancellous bone. Again, look at the defect, oronasal fistula. You see the oronasal fistula here, the defect, the discontinuation, we don't have continuity of the maxilla. Then here we close first the nasal floor with the nasal mucosa, with reconstruction of the nasal mucosa. We raise the flaps for the closure of the oral side. And we have the mixture, always the same, cancellous bone here, very good cancellous bone, full of osteoblasts with xenograft granules. We just opened a bottle of Cerabon 5 cc's, and after actually here I didn't put the picture. I have placed a 30 by 40 Jason membrane up against the nasal floor, and then packed the graft, and then another 30 by 40 Jason on the buccal and palatal side. You see here, pinned to stabilize everything and keep it immobile, and closure, primary closure. Put a splint here to protect it from food and tongue, and implant placement just 4 months after that, because we have a lot of good bone and faster healing bone when we have cancellous bone. After 4 months we place the implant. Look at the quality of the bone, continuity of the maxilla now, and an implant placed to reconstruct the lateral incisor. And to conclude, autogenous bone grafts, I hope I've showed you that autogenous block grafts work better than particulate bone substitute grafts in demanding alveolar defects, and that's basically one-wall defects with less complications. If you have like a 2-wall or a 3-wall defect, okay, especially with a 3-wall defect, you can go ahead and use particulate graft, especially if it's a small one. But if you have big defects, 1-wall defects, you're better off going with an autogenous bone block with xenograft and membrane. The addition of a xenograft and a collagen membrane gives a more stable result as far as bone gain is concerned. Horizontal bone augmentation, you have to expect it to be more predictable procedure than a vertical bone augmentation, but vertical bone augmentation works well too if you do it correctly, do an autogenous bone block covered with xenograft granules and a membrane. And of course, meticulous surgical technique and attention to detail can make the difference between success and failure. And with that, I want to thank you for watching the webinar, and I hope I didn't tire you too much. Thank you. So let's see some of the questions. Dr. Gunaim asks, should the graft be covered by periosteum? Covered by periosteum? Well, it's going to be covered by periosteum, but after you cover it with a membrane, as I told you. So first the membrane and after the periosteum. The periosteum is not a GBR membrane. It doesn't protect your graft. So use a GBR membrane. Dr. Norero asks, and thank you, what is the difference if I use a titanium mesh? Titanium mesh, you can use it, actually, you can fixate your particulate graft better than a membrane, but it is not tissue friendly. And sometimes flaps tend to open up. And sometimes you may see flaps opening up 2, 3, even 4 months after reconstruction. The good thing is that if the flap opens, if you see the titanium mesh exposed intraorally after 3 or 4 months, then probably almost all of the bone augmentation, bone regeneration will be done up to then if you have used autogenous bone. So it's not that much of a disaster. But if you have a titanium mesh opening up in 3 months and you have used only particulate like an allograft or a xenograft or a mix of allograft and xenograft, that can be a disaster. Dr. Gunheim, again, is decortication cortical plate required? That's a very quick question, very good question. I always get this question. My opinion, no, it is not required. As you have seen, I don't do it. I don't do cortical plate perforation because actually some people say it's worse to do it because you create holes and you create a metabolism on the bone, on your host bone for osteoclasts to come out and resorb your bone. So because I only use autogenous bone on the host graft, on the host bone, I don't really need to do cortical plate perforation. All the cases that you have seen, and actually all my cases, I never do cortical plate perforation. You don't need to do it if you're doing bone blocks. Now it's another question if you're trying to do a horizontal graft augmentation with particulate graft. I don't really do that kind of technique, so I'm not the best person to answer that. Dr. Petrov, is CAD/CAM Bone Builder any better? Well, I haven't used it. From my experience, if I understand your question correctly, CAD/CAM Bone Builder is allogenic bone. I don't use allogenic bone blocks. I don't trust them. Actually, there's not enough long-term data on allogenic bone blocks, and they have elevated complication rates, and they have questionable, if any, osteoinduction. So I don't like using allogenic blocks, and I think that the CAD/CAM Bone Builder is with an allogenic block, so it would not be my choice. Must the membrane be covered by periosteum? Yes. When you do big reconstructions like that, you need to, if I understand your question correctly, probably you either mean primary closure, or if you mean primary closure, yes, you have to have primary closure. So every time primary closure. Now, does the membrane have to be covered by periosteum when you have primary closure of the flaps? No. Actually, when you do when you cut the periosteum to do a sliding flap, the part of the flap that will be without periosteum may be above your membrane. It doesn't really matter. If your membrane is stabilized and pinned and stable at its position, it will protect your graft. If I understood your question correctly. So no, the membrane doesn't have to be covered by periosteum, but in these kind of cases you have to have primary closure. I don't see another question coming in. So I think I tired you enough. At this point, I'd like to thank all of you that stayed up to now in the webinar, and I want to thank also again botiss Biomaterials for inviting me for this webinar. Thank you very much.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.